Child abuse and neglect can be classified according to this table. We can have physical neglect or abuse and psychological. In terms of physical abuse, most commonly these involve things like bone fractures and bruises and burns to the skin. Examples of physical neglect are not providing appropriate food, clothing, school, medical care, and safety precautions to children. Psychological abuse and neglect can again be divided in the same way. Psychological abuse is doing things like terrorizing a child, putting down the child in front of other people, comparing one child to another child, or insulting a child publicly. Whereas, again, psychological neglect is the lack of giving appropriate parental love, support, stimulation, and recognition to that child. Specific definitions related to child abuse and neglect are, first of all, maltreatment. These are abusive acts of either commission or omission that result in any kind of morbidity or mortality. Physical abuse is intentional injuries accompanied by any form of short or long-term emotional consequences. Psychological maltreatment is intentional verbal or behavioral acts or omissions that result in adverse emotional consequences. We may have sexual abuse, and finally, much less commonly in children, factitious disorder. This is the newer word for the older Munchausen syndrome, which intentional deceptive actions to simulate a disorder and typically fool other people and medical providers. The most important consequences of child abuse and neglect are failure to thrive, developmental delay, the beginning of learning disabilities, repeated physical disabilities, and even death. With respect to the epidemiology of child abuse and neglect, these are things that we typically learn in our behavioral science courses. We know, for instance, that the likelihood of abuse increases in caregivers who have had a history of abuse themselves as children, young parental age, particularly teenagers who are unmarried, those with closely spaced pregnancies, those with lower socioeconomic status, those people who have spousal abuse themselves, parents who have substance abuse, physical disease, chronic illness, mental retardation in a child, children who are low birth weight, children who are premature, all are more likely to be abused, and in any situation that results in a chronic high stress level. A 2-year-old boy presents to the emergency department with a skull fracture that the mother states the child acquired after falling from a sofa onto a carpeted floor. During the physical examination, the child is alert. He is noted to have old bruising on the buttocks and back, as well as cigarette burn on his palm. The mother states that the child falls a lot and is always touching things he should not. The two most important things to consider in terms of the possibility of diagnosing physical abuse in children, most importantly, is an unexplained or implausible injury. That is, an injury or injuries that when you hear the history from the caregiver, whether it's a parents, or another caregiver, seems to you to be completely unexplained. It doesn't make sense in terms of how this is reported to having been caused actually is the way that it could have happened. Along these lines are multiple injuries in different stages of healing and injuries that have certain patterns to them. That is, you can identify them as looking like something that may specifically have caused them. Classic example is a round cigarette burn, or perhaps the tip of an iron that you use to iron your clothes. The other big feature is a delay in seeking medical care. Parents should exercise good and what we consider to be normal parenting skill, so that if a child has significant injuries, they are brought to medical attention as soon as possible. With respect to falls, which is one of the scenarios given in the vignette, here's what we know. Falls in children of less than 3 feet rarely result in simple linear fractures of the skull or the clavicle, most commonly. Less than 6 feet, they rarely result in concussion, a subdural hematoma or laceration, and falls up to about 10 feet. Typically, with these, there are no reports of death or any serious injury. It is important for the caregiver to report all cases of child abuse and neglect, whether it's physical or psychological, during the process of working up the patient, whenever the caregiver feels that indeed may be possible. It doesn't have to be probable. You do not need the burden of proof immediately. If you do not do the appropriate workup and reporting, and it becomes evident later from somebody else that the child has indeed physical or psychological abuse or neglect that you may have known about that did not report, then you are certainly liable from that with respect to a medical and legal standpoint, and bad things can happen. On the other hand, if you do a report to the Child Protective Services initially, and all of these cases will eventually go to court, and if the court, whether it's by a jury or by a judge, find that they don't think that this is abuse, then you are not going to be held responsible for that, as long as you have acted within the realm of reasonable medical judgment. So what do we want to do whenever we think that we have child abuse present? The most important part of the examination is the history and the physical, with a careful developmental and neurological examination and documenting everything in your notes, including drawing and photographing all visible lesions present. In addition to this, if we suspect a lesion, a form of trauma that isn't absolutely visible, let's say a non-displaced, non-compound fracture, maybe a spiral fracture, then obviously any kind of examination, laboratory study that is necessary to prove the diagnosis also has to be done with the history and the physical examination. That in this case would be an X-ray. Also remember that always in child abuse, part of the physical examination involves doing a dilated retinal exam. So we dilate the pupil and do a retinal exam. If you don't feel comfortable doing that, then you need to get an ophthalmologist to do that immediately to go along with the rest of your history and physical examination. And this is particularly important in the very young child, where we can have multiple forms of physical abuse occurring together. And the point is we want to look for any evidence of retinal hemorrhages, which may be part of the shaken baby syndrome. It's after the history and the physical and any other test that we need to establish whatever trauma has occurred that we then decide whether this is possibly child abuse or not. And if the answer is yes, this is possibly child abuse because of the things that we talked about previously, then the next step in management is wherever you are seeing the child with whatever caregivers the child is with, you want to physically separate the child from the caregivers at that particular time. So somebody else can take the child to another area of wherever you are, an emergency room or a clinic or an office, and sit with that child or perhaps clean up their wounds. The point is twofold, that the American Academy of Pediatrics feels that in a number of cases, particularly with verbal older children, that they may start talking and giving important information which can be documented. And the other thing is to prevent the caregivers from all of a sudden picking the child up and running out, particularly if you have to leave the examining area for one reason or another. Now, at this time, keep in mind, however, that nowhere have we reported this. This is not, completely in the legal system at this point. Therefore, the parents, the caregivers, still have rights. And at this point, if they say, no, I'd rather have the child to stay here with me, then by all means, you allow them to do that. However, at the next point, then, we now need to notify the Child Protective Services, and in many states this requires notifying the police as well, and it's generally one of the people from the Child Protective Services who can notify the police. Now, once this has occurred, it is then in the legal system, and the person from Child Protective Services, there will be a caseworker who will be the guardian ad litem for the court, who will be working with the child and the family until this gets to court. The Child Protective Service person also is the person who refers the child for placement. Ideally, what will happen is until the case goes to court, the child may be placed in a safe environment that is a relative or a close friend or a licensed foster facility. And if no place can immediately be found, perhaps a place may be found later. Until that happens, if the only safe environment is the hospital, then that is in fact exactly what happens. The parents can never visit on their own. It always has to be supervised, but we want them to do that because the ultimate goal is to rehabilitate the caregivers, the parents, or the parent, whoever the perpetrator is, so that ultimately the child can come back and be safely followed within the realms of being part of the family again. Now, after we have done this, we come back and we've informed the caregivers exactly what we think and what we have done already. That is, that it's been reported to Child Protective Services and, again, in some cases to the police, so that they now essentially have no more rights into determining that we are, as medical caregivers, are or are not allowed to do anything. If they do try to create a problem by saying you are not doing this, you're not doing anything else, you're not doing this test or that test, you're not taking our child away for any period of time, then your next step in management at that point should be to get right on the phone and call the court, whereupon you will get a judge, and that judge will issue an emergency injunction so that everything remains well within the legal system and you don't put yourself at any risks in any way. If any other lab studies at this point need to be performed, which we'll talk about more momentarily, this is the time that we would do them. And finally, after all of this, it's a matter of waiting until the case goes to court, in which case the court, either again by jury or by judge, determines the ultimate disposition as to what happens to the child and the family. The most common manifestation of physical abuse are skin lesions, particularly bruises. Accidental bruising and accidental scrapes and scratches on children are typically thin and overlie bone edges, particularly extensor surfaces. Non-accidental bruises and skin lesions occur in other places, such as the buttocks, the genital area, the neck, the back, over the liver. Often what we see with multiple injuries are injuries in different stages of healing, and we can get an idea of different stages of bruising. Newer bruises tend to be blue, red, purple. Older bruises tend to be brown, yellow, green. And so multiple bruises at different stages, particularly over places where children do not commonly, again, get bruised or injured, is a key feature to the probability of child abuse. There are a number of types of fractures depending on where they are located and the age of the child and the developmental age of the child that are suggestive of physical abuse. And experts in child abuse pretty much know this material. The rest of us may not necessarily. And so often we may need to refer to somebody with more expertise before we make up our mind. And there's nothing wrong with doing that at first. Examples are corner, chip, or bucket handle fracture of the metaphyses. This often can occur because of pulling the arm. Spiral fractures of an extremity because of twisting, and particularly a spiral fracture of the femur before a child is able to walk is usually an inflicted injury. But it's very important with respect to fractures, most importantly, again, to note the possibility of multiple fractures in different stages of healing. And the only way, particularly in younger children, to do this would be to get a skeletal survey. Now, the other issue is with multiple fractures, does the child have abuse or does the child have osteogenesis imperfecta? And we talk about osteogenesis imperfecta in another chapter, but remember, at least for exam purposes, that you would not think of the diagnosis of osteogenesis imperfecta unless you were given the findings of osteogenesis imperfecta. If you think about it, physical abuse, which would result in multiple fractures that typically would be not compound, not displaced fractures, in many of those cases, the child would not come to a medical caregiver at the time of the fracture. They would just heal with callus formation until perhaps they are picked up then later because of another form of physical abuse, which we're now evaluating. So we see multiple fractures in a child who did not come to medical attention, but they again do not have any of the findings like blue sclera, short stature, sensorineural hearing loss that occur in the diagnosis of osteogenesis imperfecta. And so then on an exam, at least, there's no way possible that we could make that diagnosis. In addition, you're looking for the epidemiological factors that we talked about that occur much more frequently in caregivers who abuse children. Other fractures then that are more specific for abuse include rib fractures in infants, bilateral fractures, complex skull fractures. Other major skin findings are burns. The cigarette burn is by far the most common. We see multiple round cigarette burns in this child. There's usually a perfectly round erythematous lesion that clearly looks like a burn, often with a central discoloration or central linear necrotic area. Some of the burns can be very significant, particularly cigar burns, and can result in full-thickness burns, particularly in young children, which a scarring may result. The other important form of producing burns in children are immersion burns. That is, immersion into very hot water, usually in a bathtub. Water often in excess of 140 degrees, which can result in a young child within 2 seconds of a full-thickness burn. They typically give a glove stocking pattern. If a foot foot and leg are put into the water, or the same type of appearance with the hand and the wrist and the forearm. The most common, however, is bathtub dipping, where you hold the child under the upper part of the back and then behind the knees and dip them in so that primarily the lower part of the back, the buttocks, and perhaps the upper thighs will get uniformly burned, again in that classic description, which cannot look like anything else. There's uniform demarcation. There's lines that demarcate the end of the burns versus the normal skin. Flexion creases, that is particularly behind the knees, are spared because that's where the child is being held. And also, because the most common thing that caregivers say occurred with the child who has this type of finding is that they fell into the tub of water. That, of course, with these distinct line of demarcations and the fact that there are multiple splash burns as the child is thrashing and trying to get out, rules that out completely. Therefore, in that situation, the history is completely incompatible. The most common form of death, particularly in a young child with child abuse, is intentional head trauma, particularly leading to a subdural hematoma. And this should be suspected when a child comes in with acute neurological findings. There may or may not be external evidence over some part of the head that trauma has occurred. Usually there is, however. So the infant may present with a coma, with seizures, apnea, any evidence of increased intracranial pressure, change in the size of the pupils, asymmetry in terms of the reaction of the pupils, decreased reaction, that is decreased breathing, decrease in abdominal palpation. All of these, of course, if you think about it, would result in a child with a significant decrease in their Glasgow Coma scale. Once again, we'll usually hear a history that is incompatible with this. For instance, a 2-year-old falling off a toddler bed, which is only a couple of feet from the floor. We basically know that you're not going to get serious head trauma or intracranial bleeding when that occurs. Typically, no trauma will have occurred whatsoever. Again, don't forget to look at the retina. We need a good retinoscopic examination with dilated pupils because in the child in the first year to 2 years of life, we may have associated shaking, which can lead diagnostically to retinal hemorrhages. The least common form of child abuse is intra-abdominal injuries. This usually involves an impact, that is, either hitting the abdomen suddenly with a fist or with an object. The history will be that a child was previously fine, and this child typically would not have had abdominal surgery for any reason. And then there's a sudden change in situation. So the child may present with recurrent vomiting, sudden abdominal distension, absent bowel sounds, significant tenderness. Depending on the nature of the trauma, could even be in shock. So in other words, what you're looking for in the worst case is the appearance of an acute surgical abdomen in a previously well child who generally has some evidence of trauma on the skin of the abdomen over the site where the majority of the trauma has occurred. With the most common, which is a fist impact, you may in fact see a row of 3 to 4 1-centimeter teardrop-shaped bruises indicating the fingers and knuckles going into the skin over the area of trauma. The trauma may be so severe that liver or spleen may be ruptured, the intestines may be ruptured, or there may be sudden bleeding in the intestines into them. This would be called an intramural hematoma, which could result in even acute temporary obstruction of the bowel. And if there is rupture of the bowel, you may also see free air. So in other words, it's going to take a high degree of suspicion, but with the scenario that I described. As I stated earlier, after you have finished all of the rest of your workup, then you have to ask if any additional laboratory studies need to be performed. And these are the ones that we need to do, either, again, in the stable child or in the child where you suspect a significant injury and we need emergent diagnostic studies. So in any child who has any evidence of bleeding whatsoever, whether it's bleeding in the skin, intracranial or intra-abdominal bleeding, we always have to do a bleeding workup. So that when we are asked in court if we've ruled out a bleeding diathesis, we can say, yes, we have. So we would do the most common findings, which is PT, PTT, platelets, bleeding time, and you can even do an INR if you want to. With respect to fractures, for all children under 2 years of age who come in with any evidence of child abuse, we need a skeletal survey. That is taking honed-in x-rays on each part of the body that you would normally do to evaluate bones in that particular area of the body. Now, why under 2 years of age? Because children are not going to be verbal. They're not going to give you a clear history. They're probably not going to say anything at all. And we also know, particularly in the very young, that one form of child abuse goes along with other forms of child abuse, such as multiple fractures. And so again, what we're looking at here is multiple fractures in different phases of healing, which the radiologist can tell us based on callus formation of the bones. For children greater than 2 years of age, basically it's plus or minus, at least certainly from more than 2 to about 4 to 5 years of age. It depends again on your ability to diagnose recent or older fractures, depending on palpation, depending on what the child says. You can get the skeletal survey if you like. However, in children older than about 4 to 5 years of age, who are typically verbal, who can give you more information, where your physical examination is a little bit more accurate. Then if we suspect anything, we can take x-rays, particularly of the area of injury that we may suspect. Now, infants, again, who have had any head trauma, even if they've had no CNS findings, need, as usual, first to be stabilized. So medical care is always the first thing to do before we get into any other issues with respect to diagnosis or child abuse issues. And the study of choice emergently then is a head CT scan. This is usually sufficient. If it is not, then the best test would be an MRI. And again, remember the ophthalmological examination in terms of dilating the pupils and looking at the retina. If there is abdominal trauma, again, the most important emergent CT scan, if there is time to do it, meaning the child just doesn't need emergency surgery, is the abdominal CT scan. And any other tests that you think are warranted based on the site of the trauma and the likelihood of the injury. If you think that the urinary tract is involved, you can get a urinalysis. You can look at blood in the stool. You can look at liver enzymes for liver trauma, pancreatic enzymes for pancreatic trauma, and so on. There's nothing right or wrong here. It's use your judgment. However, again, for acute injuries, the CT scan is the best initial study. So again, the summary overall then of the management, the treatment of physical abuse, is always first prompt medical, surgical, and psychological management before we do anything else. So remember to report anything suspicious to you that is possible, it doesn't have to be probable, to Child Protective Services. Law enforcement agencies may need to be involved. They may perform forensic evaluation, interviews, and hospitalization needs to occur if certainly the medical or surgical condition requires it. If for whatever reason the diagnosis is unclear, as I stated previously, there's initially no alternative safe place for placement of that child. A 3-year-old girl with green vaginal discharge comes in, and you find microscopic examination of the discharge showing gram-negative intracellular diplococci. For this exam, we only need to be very general with respect to sexual abuse. Sexual abuse in children, fortunately, is not very common. It does happen, and we have to be aware of it. From an epidemiological standpoint, we know that the least common offender is a stranger. Most commonly reported is daughters being abused by fathers or stepfathers. But the most common overall that we find upon review of the literature is brother and sister incest. Violence is not common with sexual abuse in children, but it does increase with age and the size of the victim, and sexual abuse is more likely to occur as a single incident with respect to a stranger, which again overall is much less common. The presentation is basically either vaginal, penile, or rectal pain, bruising, erythema, bleeding, or any other acute evidence of trauma. Keep in mind that some less common presentations, and again for one which you have to have a higher index of suspicion, involve things like chronic dysuria, chronic enuresis, or encopresis. But certainly the statement that we can make absolutely is any sexually transmitted disease in a pubertal child is always sexual abuse. Based on our history and physical examination, the best method of handling this is immediate referral to Child Protective Services and the police, because our best examination is a videotaped forensic interview. Otherwise, sexual abuse is handled in exactly the same way. Child Protective Service and police notification. Psychiatric support is very important here. Again, the child needs to be placed, and careful attention needs to be made with respect to any possible infection. So that needs to be worked up. Empiric antibiotics would be used, and in the adolescent, pregnancy has to be looked for as well.